people at the start of my talk, and then nobody knows who it is. So I thought I'll break tradition, for a young guy, but I still know you don't know who that is. And it all will be revealed at the end. You mean the chief?
No, that's money man.
So before I begin this subject, I wanted to first thank Professor Khurshid Ghani. He has been a source of inspiration for me from the beginning of my urological training. People here keep asking me, did you work with the professor? How do you know Prokar and all this? And I'm like, well, I never actually was his registrar at Guy's Hospital. I worked at Guy's Hospital. I was registrar of his colleagues. And I never actually had the good fortune to actually work under him. But there's only one instance, one clinical incident where we came face to face. And he won't even remember this, but I was on call at Guy's Hospital, senior registrar. It's a very busy on call. So it was a little bit quiet, it was in the evening, and I was just about to go home, and I got a call from the sister in theatre, or OR, as you say. And she said, Professor Dasgupta would like you to come into the operating room now. And I was like, okay, what's going on? What's Professor Dasgupta doing in the operating room, number one? Why does he want to speak to me? So the first thing, as you all know as trainees, if your boss calls to speak to you, the first thing you think is, who have I killed? What have I done wrong? And so I'm walking down to the theatre thinking all these things. Oh my God, was it his robotic prostectomy that I discharged at the weekend? Did I miss something? Oh God, I'm walking. I get into the operating room, or I should say theatre, and there's like 10 people. And there's Prokar Dasgupta and Shamim Khan. And they're all just looking at me. And I was like, oh my God, what are these people? And there's a patient on the table. And I was like, they're operating? I didn't even know about this case. Am I supposed to have been here? And I haven't been here? Oh my God, I'm freaking out. And Shamim Khan goes to me, the boss wants to speak to you. And I was like, oh God, so, yes, sir. And he said, Khurshid, we can't get a catheter in this patient. Can you catheterize him? That's it, I got a catheter in the patient. While everybody's watching, flexing, what guy, what. It's in, and then he goes, wonderful job, my man. Pats me on the back, and that's it. I passed the test. So thank you very much, Professor, and thank you for supporting me to get here at the Radiculi Urology Institute.
It was a very simple test I designed to see if he was fit for the video.
Okay, so why am I talking about this subject? I'm no expert in this, I have to admit, but one of the things that surprised me about coming to the Radiculi Urology Institute when I knew I'd be working with Dr. Menon is I thought I'd be learning surgery, techniques, all this stuff. No. Let's sit down and brainstorm and think about concepts and ideas. That was a complete shock. I did not expect that. So one of the things that came across his desk was he had to do a review for European Urology on Ash Tiwari's systematic review, Metaanalysis on blah, 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 as you can see here. And I was fortunate enough to be involved with this along with Kwok as the senior author. And that opened my insight into systematic reviews. And one of the projects Dr. Menon got me working on here when I arrived is looking at the data in this institute on posterior reconstruction and what our results are over the years. So Professor Montorsi then contacted Dr. Menon and said, I have a systematic review on posterior reconstruction. So Dr. Menon summoned me and said, let's look at the evidence. And that, has brought my interest on in this subject, and I'd like to discuss some of the things to you. So, as we looked into this, and I think it was mentioned yesterday, we came across this paper, the Michael Lawlins Harveyan oration on the evidence for decisions about the use of therapeutic interventions in the Lancet. And it's a 14-page document. I implore you to read it. It is so well written, and it's a fantastic synopsis on issues of evidence-based medicine and where we are today and where the challenges are for tomorrow. Yes, Steve Rivera, where are you? Here he is, Sir Michael Lawlins, and this was a Time article issue all about quality of life, because he is the chairman of the National Institute of Clinical Excellence in the UK. And of course, they were the ones who started this whole process of cost effectiveness and evidence base. What treatment can you give? What treatment can you not? What's the evidence? So in this talk, I'm going to give you a brief overview about evidence-based medicine. I can't do everything. It's only half an hour. I'm going to try to stick to time. So I will talk briefly on how you should appraise evidence, on the approach to systematic review, so that when you get a systematic review, how should you look at it? And then I'll briefly touch upon some new criteria for assessing evidence called GRADE. So what is evidence-based medicine? So this is probably the best definition from Dave Sackett, who is the pioneer of this from Oxford University. Evidence-based medicine is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. And the way of looking at this is evidence-based medicine constitutes both best research evidence, clinical expertise, and puts the hearts of the patient care at the matter. So what is evidence? Well, the best way of thinking of this is the value of evidence can be ranked according to its potential for bias. So bias is the key word. And you can see the boxes here: primary evidence, which is original research; secondary evidence, which is compilation of that. So one would say a systematic review is secondary evidence. And then you have tertiary evidence, guidelines, which you've touched upon already, we're just talking about. So maybe there's quaternary evidence, which we haven't come across yet, which is guidelines of guidelines. So when we talk about evidence, everybody knows about levels of evidence from the University of Oxford Centre for Evidence-Based Medicine. And there's 5 levels, and it's a hierarchical model with at the top level 1 being systematic reviews, and then you've got an RCT as level 1B, and then underneath that, level 2, you've got cohort studies. So RCT is level 1, but level 1B. And I just want you to remember that, because we'll come back to this later. Who cares? Why bother? Well, William Osler thinks it's our duty to keep learning, and this is a development of medicine. This is what we're learning. But who cares? You don't need to. But we care in the UK because we have no money, it's raining all the time, everyone's bankrupt, the euro's about to get exploded, and who cares in America? I don't care saving money, but I think from Kwok's talk you know that these are the big issues about insurance companies and cost effectiveness. So it is coming here. It is coming here. You still don't care, do you? Well, you should. All the papers are showing a rise in evidence-based medicine methodology. If you look at different guidelines on how to write papers, Consort, Quorum, STAR, Strobe, the number of citations for papers using these guidelines are increasing. So what? I don't care. The Cochrane Review care. They look at RCTs only and come up with evaluations and then recommendations. So if you look here, number 7 in their top 50 reviews, primary for preventing UTI, and they give you a recommendation. They synopsis the evidence, but you still don't care, do you? Well, you should care now. You care. This damn page. This bloody page. What a nuisance. Doesn't fit with the guidelines. Other evidence base. Well, what's the evidence on MRI for low volume disease and active surveillance? Because you get challenged. So you should care now. So how do you appraise the evidence for MRI active surveillance? Well, I think what I want you to remember is this. Peacock and Rambo on the gate. That lady there is Mimi Peacock. She's an elementary school teacher from Woodland Elementary School in Louisiana. I have no idea who she is. I Google searched Peacock, and it's the first person who actually has a surname Peacock, P-E-C-O-T.
Are you sure it's not Money Menon?
Actually, it's you, Professor Dasgupta. So, Peacock. You know who Rambo is. He spilled first blood. Gate. So this is the way you should, in your mind, when you look at a study, appraise the evidence. And it stands for the Graphic Appraisal Tool for Epidemiology. I'll go through it in a minute. EGOT. So the participants, who were they? What was the exposure group? What was the comparison group? What was the outcomes? Dichotomous outcomes. Yes, no. You can have multiple groups, you can have multiple outcomes. And what was the time frame? Was it an incidence? Was it a prevalence? And when you read a study, this is how you should jot things down, in this graphical format. This is what is now being advocated by the Oxford group, by the Ottawa group in Canada, and by the Auckland group, and the Newcastle group. These are the 4 big centres of evidence-based medicine. And when you look at participants, you can narrow it down from those who were probably eligible and ended up actually becoming part of the study. So this can be applied to all studies, cohort, RCTs, cross-sectionals. And I'm not going to spend too much time on this, but I just want you to remember that every epidemiological study hangs on the gate frame. So what about Rambo? When you assess studies with gate, you should think of Rambo. What was the recruitment? What was the allocation? What was the maintenance? Did all the patients complete the study? Were they blinded? Were there objective measurements? Was it an IIEF-5 for erectile function after robotic processing, or was it just a physician interview? So on to the heart of this topic, which is systematic reviews. This is the PubMed snapshot of 34 of systematic reviews in urology so far published this year. And you can see that the esteemed professor has one in number 2 there on current status of validation for robotic surgery simulators. So why are systematic reviews important? Well, the first thing, there was a key study done by Antman that was published in JAMA that looked at RCTs and found that when people began an RCT, they were wasting their time. The answers were already there if they'd just done a systematic review. And so when that came out, big funding bodies like the Medical Research Council then said, if you're going to apply for an RCT, we need to see the systematic review first. No systematic review, no RCT. So that became the norm. And then if you looked at the cost of an RCT versus a systematic review, it's much, much cheaper. 1/150th of the cost of an RCT. And a lot of this work was pioneered by NICE, the National Institute of Clinical Excellence in the UK. Whether you like them or not, I think they have added to this body of work. So when we look at systematic reviews, this is the recommended reporting system. It's called PRISMA, which is the preferred reporting items checklist for systematic reviews and meta-analyses. It was published in the BMJ, and this is how you should look at a systematic review. And we're not going to remember this, but if you see a paper that says, I followed PRISMA, that should clock in your mind and says, okay, this is people who are trying to maintain the standard. And it's a 27-item checklist. Blah, blah, just like the consort guidelines, I guess. Only 5 of the 32 systematic reviews so far this year in urology have followed these guidelines. So let's look at one of the recent systematic reviews that was published from the Mayo Group. Simon Kim, who is now a friend of Dr. Trin's here, and they looked at what Dr. Rogers was talking earlier on, partials, radical nephrectomy for survival and renal function. And they did a systematic review, a meta-analysis. So what's a meta-analysis? It's the use of statistical methods to summarize and combine the results of independent studies. And they showed their data on a forest plot. What's a forest plot? It's a quantitative estimate of the net benefit aggregated over all the included studies. So you have favoring radical nephrectomy to the right, favoring partial nephrectomy to the left, and if the overall combined estimate, when we looked at posterior reconstruction for robot-assisted radical and radical prosthetic in general, the Rocco group was a multi-institutional analysis. They followed the PRISMA reporting guidelines, and they whittled it down from nearly 5,000 records down to 11 studies that looked at this. And then they looked at many outcomes, but the one I'm going to focus on is the short-term, early continence recovery at 30 to 45 days, and they found that there was a significant result in favoring reconstruction. Now you can see this, but again, you have no idea here which is the randomized trial, which is the retrospective study, which is the prospective cohort study. You have an idea of how big the studies were because there's a weightage, but again, it lacks some information. Of the 11 studies, 8 were on robotic prostatectomy. Some were on open and one was on lap. So it's a real mix. It's a real melting pot of studies. So there's a lot of questions that when you look at this, you should ask yourself. What studies contribute to the melting pot? What is the risk of publication bias? So I mentioned Dr. Stricker's study because Dr. Stricker's study was a negative finding. It showed no difference in posterior reconstruction, and it was one of the 11 studies included. But because Dr. Stricker's group looked at the continence at 70 days or 60 days, and it didn't fit in their 30-day model, they excluded it. But that was the earliest point that they looked at continence. So as far as one way of looking is he tried to look at early continence, and he found no difference in his opinion of what constitutes early continence. How consistent are the results of the studies? And I'm going to touch upon this in just a minute. And is it fair to look at robotic studies and open studies together? What advantage does 3D vision impart when you do anastomosis? And how about the objective measures? I mentioned Rambo and the measurements. Is pad weights the same as questionnaire-based I'm leaking? Or just how many pads do you use? Well, I use 5 pads, but I can't stand just a little drop in each pad, so I just change the pad. Is it kosher to put all these different types of studies into a meta-analysis and then look at a forest plot? So a good example of this was published in the BMJ, and you can see that there are vastly different results in the forest plot if you look at cohort studies. When you looked at cohort studies for the association between beta-carotene intake and cardiovascular mortality, the cohort study showed that there was a reduction in cardiovascular mortality. But when then you looked at trials, there's an increase in cardiovascular mortality, and that's a really big difference. So you have to be careful how you look at your studies within the meta-analysis. And then one thing I wanted to touch upon is the heterogeneity, so the consistency between the studies and the meta-analysis. And the one thing I want you to remember is the I2 test. So this is the test that's done to see all those studies, how consistent are they? And an I2 of 0 is great. The studies were consistent. You have some confidence in them. I2 of 75 and above is considered high. So inconsistent studies within the meta-analysis. So what does the I2 of that forest plot that I just showed you? 82%. It tells you that's inconsistent. So you have to be careful about when you see the evidence. Just because you see a pretty graph with something on that one side, you have to look at it closely. Look at this meta-analysis on medical therapy for stone passage rates from Hollenbeck's group at University of Michigan, published in the Lancet. They divided the groups between controlled, these are all RCTs, but some of the RCTs didn't have a control group. And look at their I2, 2.3. It's a really tight meta-analysis, this. But again, it doesn't tell you what the drug was. Is that nifedipine? Is it an alpha blocker? Is it a non-steroidal? It doesn't tell you that. This is just medical therapy. It's in the paper, you tease it out later, but just looking at that, this is not related to alpha blockers. So the other thing you have to consider when you look at systematic reviews is the funnel plot. And the funnel plot is the graph of the effect against the sample size. And if you see an asymmetrical plot like this, it means that there's a bias. You've excluded some of the studies that would have shown you a different result. This is the funnel plot from Tiwari and al.'s publication on outcomes of open, laparoscopic and robotic prostatectomy. And you can see, it's very difficult, I guess, to project, but they look at overall positive margin rates, and then they look at complication rates, and robotic was superior, and they try to see the symmetry, and they say that it was symmetrical, so therefore they're minimizing the bias. You could argue that maybe one of the graphs is not so symmetrical, maybe they're biased in thinking it's symmetrical, and but you have to be aware of that and interpret the data accordingly. So back to the evidence. We discussed this yesterday, the POPAT study from Professor Dasgupta's group, and he said, well, this was not level 1 evidence, this was level 2 evidence. It was good, but we needed level 1. Do you? Do you need level 1 evidence? Or what we think is level 1 evidence. What is level 1 evidence? It's an RCT, I think, right, when we looked at those, at the table earlier on. Well, look at the change in that percentage changes in clinical parameters. 318% change in the maximum systometric capacity, a 77% change in the leak rates. These are massive differences. Is this not good data? Why can't you trust this? Why does this have to be put into a lower category than an RCT? So I want to then bring on the concept of signal to noise. And when you look at cohort studies, if there is a dramatic effect in the actual signal, meaning the treatment effect, against the background noise, which is the expected prognosis, and if the ratio is more than 10 to 1, then that constitutes, according to Paul Glazo, who is the professor of at the Oxford Centre of Evidence-Based Medicine, that constitutes a significant study, and it could be considered equivalent to an RCT. And this led to a thinking in the classification of levels of evidence, which was published last year from the Oxford Centre. And RCTs are no longer, for intervention analysis, are no longer considered level 1. It's a level 2. Systematic reviews are level 1. And cohort studies with massive dramatic effects are now level 2. So if you have a big dramatic effect from a cohort study, you can put it in the same category as an RCT. So the last thing I'll touch upon is grade. And this stands for the grading of recommendations, assessment, development, and evaluation. And this is a new approach to rating the quality of evidence. So this group, which consists of the Oxford group and all the groups I've just mentioned, came together and said, when the USPSTF make a recommendation, it says A, B, whatever, and then when NICE makes a recommendation, it's some letter, and somebody else makes a recommendation, some letter, and level 1 is RCT, but now we're saying level 2 is RCT. It's so confusing, there's no uniformity. So this is the new framework from now on to try and grade evidence into just simpler terms of high, moderate, low, and very low quality of evidence. So when you look at the evidence, you then have to try and grade it into these different categories, and you use a system of upgrading and downgrading depending on various factors as demonstrated in that table. So this is something that's coming out recently, and I think we'll see more and more guidelines and associations following their recommendations for both grading the evidence and for giving you a grade for recommendation of guidelines. They use that to then provide an evidence profile, and this was done by Philip Dahm in Florida, who then looked at, as an example, he looked at alpha blockers for stone passage rates, and then looked at the evidence, and then, and it's a more concentrated, a more detailed way of looking at the evidence rather than just that meta-analysis that you saw from the U of M group. So back to the evidence for posterior reconstruction. This was the evidence presented in the European Urology manuscript, which I think has some flaws. And I now give you the world premiere of a new way of looking at evidence. Somehow they published this. I don't know how, but we got away with it. And it's in our editorial. And this, typical Dr. Mellon, let's do that, just one day, that's how it happened, And what we're trying to do here is give you a visual representation of the absolute differences in continence in all these studies. So you see the bottom row, you have patients who went from a 30% continence to an 80% continence, such dramatic effects with posterior reconstruction. And they are thin lines because they were statistically significant. But the only studies that were randomized trials are the blue thick lines up at the top. So it tells you they're randomized trials because they're in a different color. They're thick because they're not significant, but they're not significant because you can see why. If you're having good results anyway with your continence and then you develop a reconstruction technique, the chance of change, of improvement, is not statistically. If you're already having bad results and then you adopt reconstruction, your chances of improvement are much better. And that's an important concept to think of, and that doesn't come across when you look at those statistics and those graphs. So in summary, the things I would like you all to remember, if you can, from this talk is that when you appraise evidence, you think of Peacock and Rambo on the gate. When you look at systematic reviews, you ask yourself, have they been reported using the PRISMA checklist? When you look at a systematic review, you look for the I2 test and see what the score is. Is it 0, which is good? Is it high, close to 100, which is bad? I want you to remember that in the new guidelines of levels of evidence, a cohort study with a dramatic effect is classified as the same level of evidence as an RCT. But I also want you to be aware that there's a huge debate going on about levels of evidence itself, and that hierarchical models are flawed in some manner. And there's a new group looking into this, and it's called GRADE, and they're rating the quality of evidence and trying to give more uniform recommendations for guidelines. So I don't want to disappoint you all. Anybody know who this is? It's not Tom Cruise.
Walter Cronkite? No.
Archie Cochrane, a physician from Scotland who became a professor of medicine and went to Cardiff in the 70s and set up the first epidemiology research unit at the MRC. And this is the Cochrane. This is the guy who set up the Cochrane collaboration and library. Okay, thank you very much.